السلام عليكم فهد you are muted. السلام عليكم.
وعليكم السلام ورحمة الله.
أهلا
السلام
وسهلا دكتور
عليكم.
محمد. أهلا وسهلا
حياك الله.
دكتور محمد. مرحبا دكتور محمد.
حياكم الله
أهلا
معنا.
وسهلا محمد، كيف حالك؟
الله يسعدك ويسعد خير ونعم الله ويحفظك.
Good
آه،
evening doctor. Good morning Dr. Pooja. مرحبا سلامة مرحبا خلود. هاي بوجا.
السلام عليكم.
Good
تفضل.
morning, everybody.
دكتور.
تفضل فهد.
Okay, good morning, good afternoon, and good evening for everyone. It really gives us a great pleasure to welcome you to the 37th MENASO Educational Academy Cerebrovascular Grand Round and the first webinar in 2024. Today, we are delighted to have you all with us for an exceptional event that play a crucial role in advancing our cerebrovascular understanding for various pathology. This webinar series successfully brought together a global community for more than 7,500 participants over the last year. We owe this success for a great speakers, more than 26 of them, national, regional, and international distinguished speakers. Today is just an extension with a great guest speakers with us. So it will be an extension to the last year success. Today we have with us Professor Bouja Khatri and Dr. Mohammed Al-Mukhlafi. And now I'm going to extend the mic to Professor Said Al-Rukn for the introduction.
Assalamu alaikum everyone. Good evening, good afternoon, good morning. We are crossing a huge area with different zone timing. So I'm so glad to be co-chair today with Dr. Fahad Al-Ajlan. Fahad Al-Ajlan, just to introduce, well-known figure in the Middle East. People saw Suhail many times. So Fahad is well-known as a neurologist, stroke specialist, stroke interventionist who has been leading the stroke service in Saudi Arabia and in Riyadh. Fahad did his training at Calgary in Canada and did also his intervention is there. I believe that's correct, Fahad.
No, Suhail, I'm not an interventionist. I'm not that skilled. I left that skill to Muhammad.
Okay. So next we have the honor to have the two speaker tonight, inshallah, with two of our resident that Fahad missed to introduce them, two young stroke specialists, Dr. Khulud Abdullah and Dr. Salama Abdullah. Both of them are a young neurologist who, inshallah, will be leading in the field of stroke in Middle East and in UAE. So with no further delay, I will ask all the audience, as number is increasing, that please share your question in the Q&A bar, and we will be able to share and to discuss these questions by the end. I know Dr. Pooja, she will be with us for the next 60 minutes as she has another meeting. So I request Dr. Mohammed Al-Mukhlafi to start with Pooja, then Dr. Al-Mukhlafi, and maybe we will keep the cases till the end. So with no further delay, Dr. Pooja, you can start your presentation sharing.
Right, I will give me just 1 second here. Thank you so much. And hopefully you can see my full presentation mode now. Looks good?
Looks
Yes,
great.
looks
Thank you.
yes.
Wonderful, wonderful. So, I'll be speaking to you about intravenous thrombolysis of mild stroke, and some of this story you may have heard before, but some of it you definitely haven't heard. Even though this work of mine and our field has been going on for many years now, actually almost 10 years, 10, 15 years, depending on how you count, there's actually been a lot of action in the last year or two. So I will walk you through that. But let's just start with the basics. And I should note, can that I do have funding related to mild stroke, both in the endovascular space with an investigator-initiated industry-funded grant, and then I also have the I also was the lead PI in an industry academic partnership for the PRISMS trial, which you'll be hearing about. So let's just start with a case and make it real. Imagine you have a 73-year-old right-handed woman, and she has a history of hypertension and diabetes. Her NIH stroke scale score is 3. About 2 hours prior, she developed the onset of a very slight dysarthria. You can sort of detect it, but barely. She's fully intelligible. She has a mild facial droop on the left, a flat nasolabial fold, and she has a little bit of pronator drift, so just a little bit of weakness in that left arm. The CT scan looks beautiful. The aspects is 10. What do you do with this patient? You know, your first thought might be she's right-handed. This is left-sided weakness. It's very mild weakness. Will treatment benefit her? On the other hand, we know that, you know, even mild weakness can make an impact. And what about the things that we're not measuring? We're not going to do hours of cognitive testing in the emergency department to make this time-sensitive decision. So, you know, these were the kinds of cases that inspired my interest in this line of work personally, and I think we all struggle with daily. The data suggests that this is the most common reason that otherwise eligible patients don't get treated with IV thrombolysis, although I suspect with the increasing use of anticoagulation for atrial fibrillation, it's probably a little bit of a smaller proportion than it used to be, but still the major cause. And I'll tell real cases that I had that were making me think about this group included patients who presented with trace weakness, and then they had full recovery the next day. And you said, great, you know, I didn't need to do anything. But then you have the patient with trace weakness who worsens, and then they become plegic on one side, and you didn't treat them, and they end up with a 90-day modified Rankin score of 4. In other words, they need help taking care of themselves and they can't walk. And you just feel so bad that maybe you missed an opportunity to not have that outcome. And then a case that I particularly remember that stood out for me was a woman who had only hemisensory loss. She came to see me back in clinic. I hadn't treated her with thrombolysis, but she actually had a thalamic stroke. And she said that she had trouble with her thinking, so especially working the cashier at a busy retail store. And so her modified Rankin would have been 2. And then the case that always stays with you is when there's a bleed. And I will always remember the 80-year-old woman who was actually the cashier at the hospital gift shop that I was seeing the patient at. And she had trace upper extremity weakness and numbness. It was primarily proximal, and it was her dominant hand. But she was still able to move it. And she said, if I don't have full function, it wouldn't be worth it to me to live. So I treated her, and she had a devastating bleed and died. And she was a very magnetic personality, and it was very sad to see. So these are the kinds of cases that relate to this really tough question of what we do with mild stroke. When we think about mild stroke, though, how do we define it? The best way to think about it in the setting of IV thrombolysis is to say, who are the patients that typically were excluded from the trials? And typically they've been patients that had, quote, minor symptoms. And you can see that for really all of the major trials to date. And so when you take a deeper look, like I mentioned, mild strokes are a significant proportion of all strokes. Population-based data suggests that actually about 2/3 of patients actually have NIH stroke scale score 0 to 5. They tend to present later, and they also sometimes don't even present to an emergency department. So this is population-based data that shows us this, as opposed to emergency department presentation. So with all this in mind, we went back to the NINDS TPA study where we got the NIH stroke skill scores item by item, and we looked at the 58 people out of 624 enrolled that had NIH stroke skill scores of 0 to 5. And there were no patients with isolated ataxia, dysarthria, facial weakness, or sensory symptoms, and none that had an NIH stroke skill score of 0. That was an explicit exclusion in the manual of operations for the NINDS TPA study, although many of the investigators tell me they didn't even remember that, or maybe didn't know that at the time. But interestingly, there were also no patients with isolated hemimotor deficits that patient I just told you about, there was not a single patient who looked like that in the NINDS TPA study. And there were 2 with isolated aphasia and 3 with isolated homonymous hemianopsia. And it was presumably based on this minor symptoms exclusion, which made a lot of sense at the time. We were establishing whether this therapy with real risks was worthwhile to generally give to stroke patients. So the logic was good. But it leaves us now with this question. And so with that in mind, I got together with some wonderful colleagues who are listed here, and we worked hard to think about how to operationally define these patients with minor stroke. And what we came up with was not clearly disabling. It's a bit subjective, but it was the best we could come up with. And what we said is when you're looking at the patient at the bedside, you and the patient would have a discussion about whether the patient could still do their activities of daily living or return to work. And by activities of daily living, we're talking about bathing, dressing, ambulating, walking, toileting, hygiene, and eating. And so we taught the mnemonic bathe. And we also gave study tools, examples of who might typically be enrolled in PRISMs, but we said always consider the individual circumstances. If you're a professor who's teaching classes, and isolated mild aphasia would be disabling to you in terms of your work. If you're a violin player, even mild cortical hand weakness might be disabling. But for many patients, this would not be, some of these symptoms would not be clearly disabling. And so these were the typical patients we recommended, and I can tell you these are the typical patients that got enrolled. We also gave guidelines of who we didn't think should typically be enrolled, and that's the patient with complete hemianopsia. We know that does not recover very well. Severe aphasia, such that they couldn't communicate, neglect of significant degree in more than one modality, as well as weakness, such that they couldn't sustain their effort against gravity. And long story short, we had to stop early because of operational futility. In other words, we ran out of money before we could get enough patients for a variety of reasons. And to our shock and surprise, the treatment arm with alteplase actually favored what had a numerically lower rate of good outcome than those in the aspirin arm. So it was a 1-to-1 randomized trial. 313 of 948 were enrolled. And you can see 81.5% in the aspirin group had minimal or no disability and able to do all the things they used to do, compared to 78.2% in the alteplase arm. This was a tough spot to be in because we were thinking about doing another trial. I was in discussion with colleagues in China as well as India to do the follow-up trial because we really wanted to answer this question. And one of the things we did is we looked at this confidence limit around our primary endpoint and doing basically some posterior probability calculations. We learned that based on the data we were seeing, the chance that we were going to have a subsequent trial that favored alteplase was 23% for any benefit and 2% for a 6% benefit. And that 6% benefit becomes important because we did see the anticipated symptomatic hemorrhage rate. We saw 5 bleeds in the alteplase group as opposed to none in the control group. This was based on a fairly liberal definition of symptomatic hemorrhage, any neurological decline within 36 hours attributed to the hemorrhage. And you can see pictures of the bleeds here, some quite big, some very, very tiny. So, this was, at the time, these were the best data we had. And actually, clinical guidelines tended to change in the United States, in Europe, elsewhere. And we typically said, they bleed. We don't see any evidence of benefit. These are patients we probably shouldn't be treating. And so the recommendations favored not treating with what was back then the standard of care TPA. And I will say, as someone who led this trial, it worried me that it ended early. And could we have created a spurious finding? And was this not the right answer necessarily? It's only one trial. It was stopped early. And then on top of that, did we not have the most sensitive outcome? And maybe with a more sensitive outcome, we could have seen a benefit. So that, always has stayed with me. And luckily, to my joy, our colleagues in China did decide to tackle this question, although with a very different reasoning than where we would have been now, probably from a perspective in other countries. In China, they were pushing really to increase their IV alteplase rates. And so they were doing that even in patients with low NIH stroke scale scores, with mild non-disabling strokes. So their standard of care for these patients was to treat them. And so they designed a non-inferiority study where basically you had the standard of care, the control arm being giving TPA, and the non-inferiority group that they were testing got dual antiplatelet therapy with clopidogrel load followed by maintenance for 10 to 14 days, along with aspirin throughout. It was randomized 1-to-1, and patients were within 4.5 hours of onset. This was just published in the last year in JAMA Neurology and led by Hu-Sheng Chen. And the inclusion criteria were a similar population, not identical, but quite similar in that they were striving for these patients with the mildest deficits. They required that no NIH stroke scale score had a item had a score of more than 1, and that the items for consciousness scored a 0. And otherwise, their time window was 4.5 hours, whereas PRISM's was 3 hours. And I'll say that we're actually working on a patient level pooled analysis. So we're going to be able to really compare the patients that were enrolled in Aramis to those who were enrolled in PRISMs in more detail. So stay tuned for that. Punchline here, actually very similar to PRISMs. These patients did even better. I can't tell you why. I'm looking forward to seeing more details in the patient data to try to understand that. But what I can tell you is that numerically, the dual antiplatelet therapy had a minimal or no disability rate of 94% compared to 91% in the alteplase group. And, this was a non-inferiority study. And in fact, the results favored dual antiplatelet therapy and certainly exceeded their non-inferiority margin, which was minus 4.5% by being plus 2.3%. And this is again showing you that they crossed their non-inferiority margin, but I probably don't need to go in more detail with this slide. They did see a symptomatic hemorrhage rate that was using a more conservative definition. They required at least a 4-point decline before they would consider the hemorrhage to be symptomatic. And so their rates were 0.3% in DAPT, the DAPT group, and 0.9% in the IV thrombolysis group, which I suspect gets us in the same ballpark in terms of hemorrhage. And we'll see with the pooled analysis as well. They did have significant limitations. They had 20% crossovers, but all of their findings were robust when they looked at it in different ways, including per protocol and as treated analyses. So quite convincing in that regard. And their subgroups, long story short, all seem to favor not giving thrombolysis with one exception, and that was the NIH stroke scale scores 4 to 5. I can tell you PRISMs had very, very few patients with NIH stroke scale score 4 to 5. So I wonder if they captured what we would have called clearly disabling deficits with this group, and that will be another thing that we will explore in the future. I can tell you that when we pooled the NIH stroke scale score 4 to 5s in aggregate, in a paper that we have in press, we didn't see any evidence of heterogeneity in treatment effect. So with that in mind, two trials that by the crude modified Rankin outcome score favored antiplatelet therapy. It's tough to think if you had a more sensitive, endpoint that you would actually favor alteplase. That just wouldn't really make sense. So at this point, I think that the question is probably largely answered, but really the next question then comes, what about patients without clearly disabling deficits, but other reasons for a higher risk of disability or later decline? In other words, risk stratifying for the worst of the mild patients. And those might be patients with large vessel occlusion. Those might be patients with any visualized occlusion or perfusion deficits suggesting distal occlusions. And some have even mentioned maybe we should be location mapping these lesions and seeing what exactly where these lesions are. And maybe that would influence whether it makes sense to give thrombolysis or not. Well, the trial that has been working on this question is actually led by our Calgary colleagues, Sheila Coots And they have an international child's phase 3. It's called Tempo 2. And they're using TNK, which may have an incremental benefit compared to alteplase. So that's good that they're using TNK. They're including patients that have TIAs or NIH stroke skill score 0 to 5 with any intracranial inclusion or a perfusion deficit that would be supportive of an intracranial inclusion within 12 hours of onset without plans already to treat with IV thrombolysis or endovascular therapy. And I just heard literally 3 days ago that this trial was stopped, and it was publicly announced that the DSMB stopped this trial due to futility. So this is actually very hot off the press and very interesting information. One more trial that suggests we should not treat with IV thrombolysis. Of course, we're in the early stages. We've just heard the big picture, and I really look forward to seeing the specific presentation as well as the detailed paper. One of the things I personally particularly wonder about is the subgroup with large vessel occlusion. I hear it's about 20% of the 800 something patients they enrolled. And so I don't know if there'll be enough there and if they'll be stratified well enough to see whether there's even a hint of treatment effect for LVOs, but I guess we'll have to stay tuned. So this field keeps moving along, and it'll be interesting to see if this kind of closes the story completely. But when you get back to thinking then about our mild stroke patient with this woman, not clearly disabling deficits for her, let's just assume that we don't treat her with reperfusion therapy. What's left? Obviously, we're doing, preventive strategies. We're giving her this patient might have had new onset AFib, and we started her on a DOAC. Typically, these patients aren't going to be eligible, at least in the United States, for acute rehabilitation. So they'll get sent home with maybe some outpatient physical or occupational therapy. And so I'll just close by saying that we do need to remember, we're focused on the acute period in this session, but we do need to remember that these patients often have underappreciated difficulties after their mild stroke. And one of the advisories I've seen that I think is really useful is to consider doing an instrumental activity of daily living assessment so that you can understand, the subtle ways that their stroke might be affecting them, and the other thing is to to know that these are patients who typically then have a lower level of physical activity despite looking, quote, relatively okay. And that can be improved with exercise or structured physical activity. So I do encourage these patients to get therapy and screen them routinely for depression, fatigue, and sleep disturbances, because that's an opportunity. And I would say no matter how severe or mild your patient is or severe, it's always worth remembering. It's one of those things that I just have to sneak in because I think we often forget this is many of these patients were hearing impaired before they came. They just never dealt with it. And sometimes it can be exacerbated, their hearing impairment, because of the cognitive issues they might have. So making sure you address that head on could potentially have a very meaningful impact in their recovery and their reassimilation into their lives. So my take-home message for you is basically when a patient has clearly disabling deficits, if their NIH stroke skill score is 0 to 5, if it's clearly disabling, I don't think twice. Our guidelines wouldn't recommend doing anything but treating these patients with IV thrombolysis if they're otherwise eligible. But if they're not clearly disabling, I think we're getting firmer data than ever that we probably shouldn't be treating these patients with IV thrombolysis. And I used to say, unless LVO, and again, in a completely data absent area, only 5% of PRISM's patients had LVOs. But now with the Tempo 2 data, we'll be seeing, but I'm starting to wonder if we won't be treating those as well. And so right now we just have to wait and see. So I'll end there, and thank you very much for your time and this opportunity to speak with all of you. As you know, I really appreciate all you've been doing in the MENA region to build quality of care and stroke, and it's always such a pleasure to be with you all. Thank you.
Thank you, Dr. Pooja. Fahad, I missed to give the bio of Dr. Pooja just when she started, and I noticed that you kept smiling. So I said, why is he smiling that?
Can I take that, Suhail? Actually, Pooja is one of the leaders, and anyone who went to the field, you should be amazed by her work, especially the one related to the stroke trial and the organization of the cutting edge ideas, I would say, rather than technology. Her work starting from the IMS3 with the first generation devices until she's one of the people who delivered major trials on the latest advancement in the mechanical thrombectomy. And definitely she is the leader when it's come to minor ischemic stroke. And she is one of the leaders for the StrokeNet. So Pooja, you are one of the people that majority of people looking up to.
Thank you so much for that kind introduction, Fahad. That is really appreciated. Thank you.
Fahad.
Too nice.
Dr. Makhlafi decided to start with the cases before Pooja is leaving us. So if you can introduce Dr. Salama Abdullah.
Sure. So today we are having two of the coming stars to us, Dr. Salama Abdullah. She is the chief resident of the neurology program in Rashid Hospital. She's a graduate from the University of Sharjah. And also she's a member of the Sharjah Youth Council in the Ministry of Culture and Youth. Welcome, Dr. Salam.
Thank you so much, Dr. Fahad and Dr. Sahil. So I'll be sharing my screen. Okay, so hi everyone. I will be presenting the case on a 73 years old female with right-sided weakness. In December 2023, a 73 years old female presented to the emergency department. She's a known case of hypertension. She had history of sudden onset of right-sided weakness associated with difficulty in speech. She was last seen normal at 5:30 p.m. and arrived to the hospital at around 6:10 p.m., which was around 40 minutes from onset of her symptoms. Now, on clinical examination, patient was conscious. She had spontaneous eye opening, no gaze deviation. She had global aphasia with right upper motor facial palsy and right-sided weakness that drifts and hits the bed. Her total NIHS score was 13. So upon patient underwent neuroimaging, including CT and CTA. Her initial CT showed left-sided hyperdense M2 segment, which can be appreciated here. Aspect score was 10. CTA revealed a left-sided filling defect of the M2 segment, which can be appreciated here as well. So for this patient, who in summary had an acute right-sided weakness, she was within window. Last seen normal was within 40 minutes. She had an NIHS score of 13, aspect of 10, and left M2 occlusion. So we have decided to go for a TPA as there was no contraindication and patient was as well planned for mechanical thrombectomy. Now, after receiving the TPA, the patient went for cerebral angiogram, and her angiogram actually revealed a reperfusion of the left MCA without further need of any intervention. So this highlights the role of thrombolysis in causing reperfusion without further intervention. So she only received diagnostic angiogram. Upon discharge, the patient's status was MRS score of 1. She was discharged on anticoagulation, and the reason behind that, because patient also had aortic thrombus distal to the origin of left subclavian artery. She was also advised elective recanalization of the left ICA stenosis. However, patient refrained from the procedure due to financial restriction and was discharged. Now, there's always the concerns around the thrombolysis with the large artery vessel occlusion in terms of increased risk of hemorrhage or the fragmentation of the clot to distal non-accessible sites. That's why it's very important to highlight or brush on the current data that add the value of thrombolysis to mechanical thrombectomy and the bridging therapy itself. So just a brief highlight of the current available data. So we have here a systemic review that was done on the 6 trials where they compared direct mechanical thrombectomy reperfusion rates in comparison to those who actually received the bridging therapy, and successful reperfusion in terms of TK 2B and above was actually achieved significantly fewer in participants who only went for direct mechanical thrombectomy. And that was also more frequently observed in studies that included the M2 occlusion, such as our patient. Now, the other interesting data that is currently available is from the RESTORE registry. And basically what they did is they retrieved around 1,000 clots that were actually analyzed, and they looked at the clot composition. And they noticed that patients with the bridging therapy, their clots were actually smaller. They had less RBCs and less fibrin in comparison to those who underwent mechanical thrombectomy alone. And the final data that we have here is basically the role of the bridging therapy on the efficacy of stent retrieval thrombectomy techniques. So this is basically from the SWIFT directed trial, where they noticed that IV thrombolysis and endovascular therapy together, thrombolysis increases the odds of first pass reperfusion by a factor of 1.6. Which was also seen in SCAPE trial. However, that was not the case in Mr. Clean and Compass. There was no difference in the first pass reperfusion. But the overall, there is no actual role of IV thrombolysis on the type of the technique that is used for mechanical thrombectomy. However, generally, it's just the overall effect on the first pass reperfusion rate. With this, I would like to end my case study with a very famous note that Dr. Sale likes is brain is time. Every minute after a stroke, 1.9 million brain cell dies. Thank you, everybody.
Thanks so much, Salama, for a very interesting case with so many things. So do you want us to stop for Q&A, or should we move to Dr. Khulud?
I think it's nice as we have this case to get some input from Dr. Mekhlafi and Dr. Pooja, if there's anything different we should do, and the evidence of TPA plus MT or MT alone for these cases.
Please,
Mekhlafi,
Pooja.
you can start.
Oh, please, Pooja.
Well, okay, I'll start. I'll be interested in your thoughts too, Mohammed. But I would say that how this case was handled is exactly how we would have handled this case. I think it brings up several issues. The first is that at this point, I think the evidence supports the idea that we should be doing bridging. We haven't been able to show its non-inferiority and exclude clinically meaningful effects. And that has been done in trials where the patient actually arrived at the endovascular therapy center. So it may actually even be more important if the patient is not presenting at an endovascular therapy center. So that's one angle. And then I'll say that the other one is the M2s. And we tend to think about it in terms of dominant versus non-dominant M2s and how accessible they are. With an NIH stroke skill score of 13, I wasn't able to see the CTA for long enough, but I suspect this was a dominant M2, and we would have chased them with thrombectomy as well. So those are my first thoughts. Dr. Mohammed, forward to yours as well.
Yeah, I fully agree with that. Like IRIS meta-analysis, so there was a pooled analysis. I think that's what Salama showed. That showed patients who received bridging did numerically better than patients who went to mechanical thrombectomy directly. But these trials were mostly geared towards showing non-inferiority, and they could not show the non-inferiority of direct. Initially, the thought was with bridging therapy, with thrombolysis prior to ABT, there is higher risk of reperfusion bleeds, perhaps groin access complications, and so forth. But these studies did not show, at least, that there is at 90 days, there is more harm. If anything, there was more more benefit numerically, which was not significant. But it's interesting because we typically, when we do kind of, if we went with mechanical thrombectomy, even for proximal occlusions, odds are there might be few fragments of clot that go too distal for us to chase with endovascular means. And so that's perhaps one area that why IV thrombolysis or bridging treatment in those patient population might be helpful. And I stress one point that Dr. Khatri mentioned, that those patients with dominant M2, with the presentation is almost a kind of full MCA presentation on that hemisphere, those patients are candidate for endovascular thrombectomy, definitely. And there are kind of more distal occlusions becomes an area of gray zone, but that's not what we have in hand here. The one remaining question is whether tenecteplase would have the same benefit as alteplase. From all what we know, it probably should be the same. But for full disclosure, I'm a co-PI of a trial where we're trying to test bridging therapy using tenecteplase prior to EVT in patients who arrive to comprehensive stroke centers. So hopefully we'll have an answer for that soon as well.
So if you allow me, I have two questions, one for Mohammed and one for Pooja. Mohammed, can this patient be considered a MEVO? Or you would say that when IH of 13, it's an LVO technically?
So many of the endovascular trials had included patients with M2. And from all what we know, including from the Hermes analysis, that M2 patients, they do better with mechanical thrombectomy compared to patients who don't go or receive conservative treatment. I don't know the full inclusion criteria. I know that some of the ongoing MEVO trials are including patients with M2, but personally, I think with this presentation, with accessible, technically at least accessible clot, that I think those patients, we have enough evidence to say that directly or taking them for endovascular thrombectomy would be justifiable.
And my question to you, Pooja, is that right now we are having, I think with the Tempo 2 hotlines, is that maybe in the intravenous thrombolysis is not the answer. But what do you think of endovascular therapy? Do you think for an LVO, not for the MEVO, that Endolo probably is the right trial, or what do you think?
That's a great question, and I think that is one of the hardest questions to answer right now. So we definitely need the trials. So Endolo now has about 100 patients in. There are actually a few hundred in the in extremis trial, and they're randomizing patients who have a large vessel occlusion to and low NIH stroke skill score 0 to 5 to thrombectomy right up front versus no thrombectomy, but then get the thrombectomy if they decline later. And I really think we don't know the right answer. So yes, I think it's a really important question. I have not seen a trial that has had more enthusiasm and more kind of a feeling of we don't know the right answer in our field.
And I'm seeing the questions here in the question and answer box, is that people are asking, would we handle this case the same in case of primary stroke center where mechanical thrombectomy is not available? Mohammed?
I think that puts more emphasis, like there is no contraindication. For sure, I would thrombolyze this patient if they arrive to a primary stroke center.
And you would do the same as the group here did, is that you will take him immediately to the cath lab to verify this?
Yeah, so thrombolize, transfer the patient. Typically, if the patient remained the same, we may repeat the plain CT if the head in the comprehensive stroke center, if the transfer was more than 3 hours or so, but otherwise we'll proceed directly for at least a diagnostic angiogram, possibly a treatment.
Okay. Don't see any further question. What do you think, Sahel?
Yeah, there's another question there about when do you send the patients from thrombectomy, Mohammed, after taking thrombolysis?
Yes, so typically we don't wait. We don't wait for any effect. We thrombolize. We alert the endovascular team even before we start, like as we are giving the bolus or the TNK injection, we alert the endovascular team. So just because we know that odds of reperfusion with IV thrombolysis is low, they are not zero as this case clearly shows, but they are low, and therefore we don't wait for the effect of TPA. The patient is losing neurons, as Salama said, for every minute. So yes.
So regarding that question, and that what happened to this case. So when the decision has been taken for thrombolysis, it was thrombolysis and MT directly, at least going for a diagnostic. So patient alert the angio suite to be ready for the patient, giving the bolus, and while the TPA is running, patient was on the table. So that's usually the way that because few centers in the region, they will wait for the TPA 60 minutes to finish puja, then they will start shifting the patient, which is wrong behavior.
Agreed. Fully agree. You know, the tough part is in countries and places where the patient, I think that's what the next comment is where they're paying out of pocket for the IV thrombolysis. That makes a whole different equation. But as far as the best clinical outcome, it's give both and give them quickly.
Nice. Fahad, shall we move to the second case?
Excellent. And I want to final comments here. I think time is brain, as Salama said correctly, but also time is clot. I think part of the reason why this patient opened her vessels is that she was 40 minutes from onset within your center. So without further ado, I'll move to our next speaker, Dr. Khulud. Dr. Khulud is a graduate from University of Sharjah, and after that, she did her master in pharmacology and toxicology. And currently she's a third-year neurology resident at Rashid Hospital, and she's planning to join a future stroke fellowship to pursue her career in stroke and cerebrovascular care. Khulud, please go ahead and welcome.
السلام عليكم.
وعليكم السلام. تفضل.
Okay. My slides show.
Yes, Khulud.
Yes, okay. I'd like to thank our speakers. Thanks for the organizers for organizing this. It's a great honor to be here. Thank you, Dr. Sohail and Dr. Fahid. I'll jump right into the case we received at Rashid Hospital a while ago. So this is a 36 years old female, known case of dyslipidemia. Other comorbidities is menorrhagia on cyclic progesterone. She presented with a history of dizziness, right-sided facial numbness, left-sided body numbness, and imbalance that started upon waking up 7:30 that morning. Patient went to sleep feeling fine at 12 a.m. the night before. She woke up with these symptoms, making her unable to walk. She arrived to the emergency department within the next hour. On examination, patient was conscious, fully oriented, cranial nerve was significant for persistent horizontal neck spasms on primary and lateral gaze. There was decreased facial sensation on the right side of the face, but no facial weakness. Uvula was deviated to the left, absent gag reflex. Motor exam was normal. Sensory exam, decreased sensation on the left side of the body. Cerebellar exam showed clumsiness on finger to nose test and impaired hilation on the right side, while normal cerebellar exam on the left. So if we play the video on the left, there's non-contrast plain CT. This axial guts brain parenchyma appears normal, no obvious acute infarct seen or hypodensities, no signs of early ischemic changes, gray-white matter distinction is maintained, and no bleed as well. When we play the next video on the right, this is a CT angio phase 1. We can see that both vertebral arteries are narrowed. The right vertebral has a progressive narrowing, especially at V2 segment at C2, C3 level, extending to V4 segment. If we look at the left vertebral as well now, you can see that we also have focal narrowing with focal pseudoaneurysm, likely secondary to chronic dissection. So as it's I'm playing here the video, as it's a wake-up stroke, unknown onset, we shifted the patient for urgent MRI. And this is a video playing diffusion weighted imaging axial, and these are 3 axial cuts of different MRI sequences, DWI, ADC, and FLAIR. And if I can put the laser, yeah, we can see that we have hyper intense area over here, while corresponding with a hypo intensity on ADC and nothing on FLAIR. So with these, based on this patient we have a patient with wake-up stroke, no known onset, last seen normal beyond the typical window of 4.5 hours, no established hypodensity on CT brain, and no large vessel occlusion on CTA, with DWI flare mismatch positive on MRI. So this patient was a candidate for TPA, patient received TPA. Now, if we play the video, this is her CT brain after 24 hours. On discharge, symptomatically, patient improved. She was mobilizing out of bed was much easier than before. She was discharged on aspirin. On 1 month follow-up, she was able to walk completely independently. However, she had persistent decreased temperature sensation. So coming to our discussion, almost a quarter of strokes, they happen on awakening or they have unknown onset. And if we look here to the screen, we can see that we have DWI flare mismatch on the left, with an example of no mismatch on the right. So the term DWI flare mismatch describes a lesion that occurs or it's visible and measurable signal on DWI, but nothing on flare. So you can see in this diagram nicely how signal intensity is different across different MRI sequences as time passes. So within minutes of infarction, DWI have hyperintensity with corresponding hypointensity on ADC. However, in the first few hours of stroke, we don't have any signal on T2 or flare. So it's just the isotense or normal signal of T2 and flare, but it's only until 4 to 6 hours from the onset of the insult that we will have hyperintensity on T2 flare. And to understand why this occurs, we need to go to the pathophysiology of stroke at a cellular level. Or I can tell you in other words, to the pathophysiology of cerebral edema at the cellular level. So brain edema occurs and evolves in different stages. We have beginning with the cytotoxic, following the ionic and vasogenic edemas. So cytotoxic edema is swelling. It's a cellular swelling, intracellular swelling that's caused by failure of ATP-dependent ionic transport systems, leading to accumulation of sodium and water only within the intracellular compartment. Cytotoxic edema by itself doesn't cause brain swelling, and the amount of CSF is the same. And that explains clearly why we don't have T2 signal hyperintensity appearing in the first phase of cytotoxic edema. When we go to the ionic, or it's only until the ionic, or more accurately, the vasogenic, where we start to see the T2 signal changes. And this is because of the progressive accumulation of water in the extracellular compartment as a result of increased permeability of the capillaries to large molecules. And this is how we use cellular pathophysiology to translate to radiological findings that can guide us clinically. So last but not least, here is like a summary of the clinical trials that have looked on IV thrombolysis within out of the typical window of 4.5 hours due to unknown onset or delayed presentation or wake-up stroke. For the sake of time, I have highlighted the studies that have utilized DWI flare mismatch in their selection criteria, and these main studies are MR Witness and wake-up trial. And these both have concluded that both they have a favorable outcome with patients treated with IV thrombolysis only if they are selected with DWI flare mismatch positive. Another interesting trial was the TWIST trial that was published in around similar time last year. It's a negative trial showing no better functional outcome at 90 days with higher symptomatic hemorrhage in tenecteplase treated group. However, the mode of selection, as you can see, is non-contrast CT. So maybe that was the contributing factor. To conclude, alteplase has been established as a stroke treatment for more than 20 years. Last seen normal within 4.5 hours is used as a surrogate for determining the eligibility for thrombolytic therapy. Studies, they have suggested that many patients with wake-up stroke may have likely had the event within few hours of awakening based on imaging characteristics that can match those of patients with defined time of onset. And I will conclude with the same statement. Thank you very much.
Thank you so much, Khulud. That was an excellent presentation, and we are happy that the patient was discharged with an excellent recovery.
Luckily, yes.
So we'll open the floor for discussion. I don't know, Pooja and Muhammad, do you have any comment about the case?
Yeah, I'll say that is precisely our practice. We are doing MRIs for our unknown onset patients, and we were worried that we wouldn't be able to get the MRIs quickly enough at some of our smaller hospitals, but we've actually been able to do it quite well. Sometimes we do have to transfer the patient for an MRI, which isn't ideal, but we've even done that. A couple of things that I always think about in these kinds of cases. First of all, it was an outstanding presentation. Nice work on that one and the one previously. I'll just note that, having talked with the person who led that trial, Gotz Tamala, one of the things that stays with me is they taught the investigators that it wasn't even flare DWI mismatch, but it was marked flare DWI mismatch. So they had examples, and I see some nodding. They had some examples in their training material I was able to see where there'd be a little faint flare change, but they would still enroll those patients. So I think that's a good thing for everybody to remember.
Yeah, it should be less than 1.1 signal ratio. That was pointed out. Yeah, exactly. But for the sake of time.
Yeah.
Yeah. It's very good point to point out.
Yeah, and we don't always measure either. But in theory, they suggested measuring, but they said, even if it's faint, you should consider treating. So yeah, sounds like we're on the same page there. And then the other comment I'll just make is, one of the areas of gray zone is when you're quite convinced they have an ischemic stroke, but their DWI is negative. So then you can't really find that corresponding flare. And my team, we've been debating this. In fact, it was actually a big debate last week we had about a case. Because on the one hand, you could argue they're DWI negative because the stroke is so small and, it's early. But on the other hand, you could say, but if you can't see it, then how can you time it based on flare? And I can't tell you I know the right answer. I've been meaning to ask Gotz that question as well. About whether we should treat those patients. But I think if I had a really convincing case that was DWI negative, I'd be tempted to treat them. But I'd be curious to hear others' thoughts too.
Ahmed, if this case showed up in your hospital at your emergency, whereas few steps from your cath lab, would you do the same or take it directly to the cath lab?
No, I would have done the same. I think if it would be a different discussion if it was a large vessel occlusion, clearly large vessel occlusion. But here, I think with a PICA presentation, like a lateral medullary syndrome presentation, I think MRI, definitely there is some data scattered about using CT for wake-up stroke in non-LVO population, but I think with an unexpected small kind of stroke similar to that presented, I think an MRI would definitely be helpful in guiding whether there is a DWI flare mismatch or not. But if it was a large vessel occlusion, I think it's a different discussion. But that we don't need necessarily an MRI. We have good evidence from diffuse, dawn, and more recently with Mr. Clean late that just relying on CT scan or CT angiogram or CT perfusion would be sufficient in these cases to select patient with benefits.
So I would give this question maybe for you, Pooja. Non-contrast CT or MR, which is the best initial test for stroke?
My perfect world that does not exist, I would have, at least in my center, I wish I had an MRI in the emergency department so I could get flare DWI mismatch, flare DWI mismatch at the same time as my perfusion imaging, but I don't have that option. So at least what we do, our protocol is if they have an LVO and they're within 24 hours, we go to CTP. If they have no LVO and unknown onset, we go to MRI because we know either of those adds time and we can't get both sets of data at the same time. There are a handful of centers in the US that can get both at the same time. So that's my thought process for and then I'll just add the reason I prefer MRI for unknown onset is because I will capture more patients I can treat, specifically the lacunar strokes. They're not going to be very likely to meet CTP criteria for extended time window treatment.
If you will allow me here, Fahad, just to add a few things. At the level of the region, there's a practice where MRI will be done for all acute stroke, and that will take a long time to open the MRI to shift the patient because it's not in the emergency. Despite that, they have a CT in their emergency. So the right protocol with that setting, if the MRI is going to happen within the next 5 minutes, and the protocol of stroke is less than 8 to 10 minutes, yes, you can go for the MRI. But if the MRI will take 45 minutes, 1 hour, no, please go with the CT angio. Do you agree with that, Pooja?
Absolutely. And actually, just to clarify, no matter what, we always do the CTA up front. It's just a question of whether we go to CTP or MRI after that. Am I hearing you say that you do CTA, CTP upfront, or just CTA?
Currently, we used to have the CT perfusion. Currently, that's we are working on getting that software again, but currently we are doing CTA. Yeah. But CT perfusion is there, but software for the last 1 year wasn't there.
Well, and arguably now that the large core data are coming out, maybe we need CT perfusion less and less. So yeah, we'll see. That's for another session.
That's another session. It's coming soon. Yes. Is there more questions?
Yes, and there is a good one for Mohammed. Mohammed, there is a question. If you give thrombolysis to the patient and he improved directly, do you still refer him for a thrombectomy center?
I mean, it depends. Ideally, yes, I would say in case kind of, unless they want to repeat the imaging right away and see is there still an occlusion or not. But ideally, like it's for continuing care, and in case there was a distal migration of the thrombus to an and it's still an accessible area. But I mean, that is a logistical kind of question, but I think it's reasonable. If the patient went to NIHSS with 0, then at least repeat imaging prior to transfer would be reasonable.
Now, Pooja, I have a question regarding your presentation. If you are planning to do the PRISM again or PRISM 2, would you pick the MRS as your primary outcome measure?
Oh, that is a really good question. You know, we don't have a better tool yet. The other argument would be, so I guess with 2020 hindsight, maybe MRS was fine. Even though it's a little bit cruder, it showed us in 2 trials that actually you're doing worse with thrombolysis. So at least numerically, for what that's worth. So I think I probably would. But what I really would like to see, and I know there are colleagues working on it, is a more granular type of measure of global functional outcomes. So we get more statistical power and more sensitivity. But we don't have that yet validated properly.
I know, Pooja, you are having another meeting at 3 minutes from now, so we don't want to take much from your time. Thank you so much for your presence. I didn't know, Sahel, if you want to say anything more.
I would like to appreciate your presentation and being with us, Pooja. Thanks for your support. Always highly appreciate. And as a promise, we are growing here in MENASO and in Middle East. Our new generation, you saw 2 examples today, and we promise our colleagues in the Middle East that more young generation will join us.
Wonderful, wonderful. Always such a pleasure to see you all. And I want to thank you all for the flexibility today, especially Dr. Mohammed, as we go start our grand rounds here in Cincinnati. Thanks, everybody. Bye.
Thanks, Dr. Thanks.
Thank you. Fahad, what's your impression about the 2 young female stroke specialists here?
Impressive, and we want more of them to the field, as it's kindly a bit dominated by males. So we want some of them to come because there is a certain topic we think it will be enriched by their presence. But the presentations was phenomenal and up to the point, and we learned from them today.
Jazakallah khair. So for our audience, thank you, Khulud, thank you, Salama. I'm going to welcome Dr. Mohammed Al-Makhlafi. Mohammed is a neurologist and a clinical scientist at Calgary Stroke Program. In addition to his training in stroke and intervention neuroradiology, he holds a master's degree in clinical epidemiology Through his career, Dr. Makhlafi has been driven by passion for finding innovation solutions to the challenge faced by patients with cerebrovascular disease. Currently, Dr. Makhlafi has been actively for the last 10 years in many publications, and he has recently published one of the landmark paper in tenecteplase and acute stroke. So today, Dr. Al-Makhlafi is going to speak about the evidence for tenecteplase in acute stroke. أهلا وسهلا دكتور محمد.
Thank you very much, Dr. Suhail, and everyone for the kind introduction and the kind invitation. So these are my disclosures. So as Dr. Suhail mentioned, that I was one of many investigators of the ACT trial that kind of compared alteplase with tenecteplase. I was the principal investigation of the imaging sub-study, and as I explained, I'm currently working with colleagues on a trial to test tenecteplase prior to EVT in patients with acute ischemic stroke. So I'll be talking kind of briefly about the history of tenecteplase and stroke. I'll go in chronological order just to show how the field evolved in thinking about the use of tenecteplase in acute stroke. Why do we need an alternative to TPA? And then what are the recent trials that came out and some of the future trials that will be hopefully starting soon. So thrombolysis was not a recent kind of treatment for stroke. The very early kind of discoveries and led to the first urokinase trial in 1986, but it wasn't until the NIMS-2 trial was published in the New England 1996 that TPA became the standard of care for acute ischemic stroke as the very first thrombolytic agent and the only treatment for stroke until 2015 when the endovascular thrombectomy trials came. Later on, this metoplase was kind of tried, but it unfortunately didn't succeed. And then obviously we had few trials with TNK, but it wasn't until 2023 or 2022 that some of these trials were published and changed the guidelines. So alteplase is standard of care. It's still the standard of care for stroke, but there are cost issues related to alteplase in certain jurisdictions. Definitely in the States, the cost of alteplase is higher than tenecteplase, but in other areas of the world as well. And then there are advantages to tenecteplase that alteplase does not possess related to workflow, and especially patients, we were talking about transfer. If a patient received alteplase, which is a bolus and then an hour infusion, the transfer while the infusion is ongoing is a big logistical hassle, which can introduce delays and can introduce errors in dosing and so forth. So these factors and others kind of prompted the search for an alternative for alteplase. And tenecteplase was one of the strong candidates, not only because tenecteplase is given as a bolus and that's it, there is no need for infusion, but it has more fibrin specificity. So ideally, it will be acting only at the site of the clot and none on a systemic level. It has more potency in terms of its half-life, which means that it will last longer than TPA. And it has more kind of less fibrinogen depletion, which again includes or contributes to its half-life. So all these factors were encouraging that tenecteplase, which is fairly similar to alteplase except in 3 amino acid domains, that it might be the next thrombolytic agent of choice. And these are some of the kind of, as I said, some of the other advantages that since it's given as a bolus, then patients who are being transferred to a comprehensive stroke center, for example, for thrombectomy, they will just receive the bolus at the primary stroke center and then get transferred. And because of its property, people wondered whether it will have better recanalization and better safety profile than alteplase. So the very first trials, which almost 20 years ago, which was a dose-finding trials done by Dr. Haley and his colleagues in Virginia, where they started with a 0.1 milligram per kg and increased the dose as kind of safety allows. And they kind of basically go to the next dose tier whenever patients have demonstrated safety without any major side effects. But they had to stop at patients at the 0.5 milligram dose because of safety concerns. So at that point, there was higher risk of intracranial hemorrhage. And so they deemed that doses of 0.4 or 0.25 were the most likely the ideal doses for tenecteplase to be tested further. And that's what he did with his colleagues. So they proceeded from this 2A trial going to a 2B randomized trial, a phase 2B. And a phase 2B is basically when our outcome is typically a surrogate outcome, so either an imaging outcome or a clinical outcome that's not the ultimate outcome. For stroke, we use the 90-day modified Rankin scale, and typically a surrogate outcome would be a 24-hour NHSS, discharge, MRS, and so forth. And so that is a 2B trial, while a 3 trial is typically a large-scale multi-center trial where people aim to demonstrate difference or non-inferiority using the 90-day MRS or an established guideline-supported outcome. And in this trial, they started kind of escalating from 0.1 to 0.25 to 0.4. And then the dose that would seem to be the winner will be progressed to the phase 3 trial. And their outcome was good neurological outcome at 3 months. But the trial, unfortunately, there was not much equipoise. At 2010, when the trial was done, that not many patients were randomized, and unfortunately, because of that, the trial was terminated early without any conclusive evidence. After that, another single center phase 2 trial, a test trial, done in the UK. Their primary outcome was the presence of a salvageable penumbra at 24 to 48 hours. So basically, patient will be randomized to 0.25 tenecteplase versus 0.9. And then at 24 hours, they have a CT perfusion. And with that, they will compare how much penumbra each patients. And clearly, if there is still present or a penumbra salvageable, then that means that there is either reperfusion or lack of reperfusion, I should say, in those patients. And secondary outcome was recanalization, early improvement, and so forth. And what a test showed that tenecteplase seemed to be superior to alteplase in terms of their kind of recanalization, actually was slightly higher in the alteplase. But overall, the two treatments were kind of equivalent. There was no major differences. A safety profile seems to favor tenecteplase in terms of any intracranial hemorrhage, but there was at least no difference in mortality that was significant, although it kind of switched the other way around in terms of mortality. But overall, it was a single center building on the evidence for tenecteplase. There were a few phase 2 studies after that, but then I'll jump to the first study that introduced tenecteplase as a superior to alteplase in patients with large vessel occlusion, which was the Extend-IA tenecteplase. That trial used a 0.25 milligram per kg dose compared to alteplase. And what they discovered that there was at least almost double successful reperfusion in the tenecteplase arm. They're basically randomized patient to either arm, and then the outcome was the reperfusion on the first angiographic run. And what they discovered that 10% of patients who received TPA had successful reperfusion on angiogram compared to 22% with tenecteplase. And that met their non-inferiority criteria as well as the superiority criteria in terms of this outcome. In terms of clinical outcomes as well, 90-day MRS, there was higher chances of independent recovery with tenecteplase than alteplase. Obviously, if there is better reperfusion, that reflects on better outcomes, but some of those patients went on to have the thrombectomy procedure, and so there might be other evidence or other effects to tenecteplase beyond the reperfusion that was seen. So that was the very first trial that was multi-center prospective randomized using imaging outcome, but also had the secondary outcome for 90-day MRS, and both showed the superiority of MRS 0 to 1 in terms of shift, at least analysis in the modified Rankin scale. They followed that with a second trial, Extend IIT K2, which compared 2 doses of tenecteplase. They were trying to see whether a higher dose of tenecteplase would be even better than the 0.25 milligrams. So they randomized patients, similar selection criteria. Otherwise, patients who are eligible for EVT randomized to 0.25 milligram versus 0.4. But this trial didn't show any statistical difference between the two, either in terms of recanalization or in terms of 0.1 or of MRS recovery 0.1 or 0.2. And because of that, basically, they concluded that 0.25 milligram would be sufficient. Symptomatic hemorrhages remained low, although they were lower in the low dose of tenecteplase, or the 0.25, almost threefolds, but this didn't reach statistical significance. But there is definitely suggestion. So these were mostly the trials that were kind of looking at patients who are EVT candidates, so almost a bridging trial using tenecteplase. There's one more trial that I'll mention for the bridging, but before that, I'll mention its predecessor, the NORTEST trial. So NORTEST 1 was a trial for all comers with stroke. So all patients who are thrombolysis eligible were randomized to receive alteplase versus tenecteplase at 0.4 milligrams. So this is the higher dose tenecteplase, but in all comers. And those patients, this trial didn't show that there was any difference. Unfortunately, it didn't meet the non-inferiority. The trial actually was testing for superiority, so it didn't show the superiority of tenecteplase over alteplase. However, there were multiple reasons for why at least this trial may have not been a well kind of perceived trial, or the question. So they didn't. Basically, they included the majority of patients were in the minor stroke population. All were treated with thrombolysis, and so the median NIHSS was 4, which is a little lower, or at least indicating that at least half of the patient had mild deficits, which will make it kind of hard to translate into clinical practice, where people are typically thrombolizing for more disabling deficits. So that was the main criticism, that there were milder stroke, most likely or potentially higher rate of stroke mimics, which may have diluted any effect for tenecteplase. But the same investigators carried on to do the NORTEST 2 trial. So NORTEST 2 was a bridging trial. So in patients who are going for EVT, they randomize them between alteplase and 0.4 milligram of tenecteplase. And this trial was unfortunately stopped early because of safety concerns in 0.4. So similar as if you remember from Extend I18K type 2 or part 2 trial, there was high risk of hemorrhage with 0.4 milligram versus the standard dose 0.25. In this trial, again, there was higher risk, and that reflected in the outcome. As you can see here, this is the modified Rankin scale. There was better outcomes in the alteplase versus the tenecteplase 0.4. So with that, kind of we know that, or this study concluded that IV alteplase is the gold standard for selected patient. Based on the Extend IA type 1 or part 1 trial, 0.25 milligram is superior to alteplase for bridging therapy, but not the 0.4 milligram per kg, which carries higher risk. After that, so in 2022, the ACT trial was presented and later published. So this is similar to NORTEST in terms that it randomized all comers, whether they are EVT eligible or not. Anyone who's present with disabling stroke within 4.5 hour window was randomized to the low dose tenecteplase, or the 0.25 versus alteplase. And I stress on the dose just because of there are difference kind of the trials in terms of the dose. The cardiologist, for example, uses 0.5 milligram per kg for tenecteplase. The dose that currently is being used for tenecteplase is half that dose, so the 0.25 milligram. And the ACT trial showed that tenecteplase was non-inferior to alteplase, so the two were essentially equivalent, although in a statistical terms, we should say that tenecteplase was non-inferior to alteplase. The 0 and 1 MRS tended toward benefit with tenecteplase, but this didn't reach statistical significance. There was no superiority of tenecteplase. But obviously, given that tenecteplase was non-inferior, given all the advantages related to workflow, that it's a bolus, as well as the familiarity of EMS staff, given that they give it for cardiology with the medication, all these factors kind of, as you'll see, reflected in the guidelines, but there was no safety concerns. So death rate was essentially the same, symptomatic intracranial hemorrhage, 3.4 and 3.2. So no safety concerns related to the use of tenecteplase. When we looked at the sub-study of patients with large vessel occlusion, so almost in a bridging style, similar to Extend-IA TNK type part 1. There was, again, suggestion of benefit with tenecteplase, but there was no statistical difference. So tenecteplase was also non-inferior in those patient population, but we couldn't show the superiority of tenecteplase similar to Extend-IA TNK1, partly because this trial this is a sub-study, smaller sample size, but there might be other factors as well. And the most recent evidence came from ATTEST-2. So ATTEST-2 was identical to ACT in terms of design. So again, patient within 4.5 hours, they were randomized to 0.9 alteplase versus tenecteplase 0.25, and then they collected outcomes similar to ACT trial. This was a pan-UK trial. And reassuringly, there were similar results as ACT trial, that there was essentially no difference between the two. Tenecteplase was not inferior to alteplase. There was no safety concerns, and these trials reflected on the guidelines, as I will show you shortly. The last trial, and by the way, ATTEST-2 and the Timeless trials both have not been published in full as far as I know. And that's why I'm showing you the slides from the investigators who presented them. But Timeless was use of tenecteplase in the extended time window. So patients who present beyond 4.5 hours, including waker-uppers, they undergo CT perfusion. And if there is a mismatch, they were randomized to tenecteplase 0.25 milligram versus placebo. And unfortunately, this trial could not show neither the superiority, could not show any difference between tenecteplase and placebo. And with that, unfortunately, we cannot say that tenecteplase in the extended time window using CT perfusion would have more benefit for those patient populations. So just to go over current guidelines, so the Canadian guidelines was updated after ACT and was presented and published. And right now it states that tenecteplase could be considered as an alternative. So it does not recommend tenecteplase as the only agent, but it is an alternative to alteplase using a 0.25 milligram per kg. The European trials, the European guidelines also suggested that tenecteplase could be a patient could benefit, or it is as safe as effective, although the expert consensus is tenecteplase should be the preferred agents, with a 9 out of 9 voting in favor of tenecteplase. So there is, at least the option is available, but for patients who are EVT eligible, both guidelines say that tenecteplase could be considered as the superior agent, although this is only based on one trial, which is the Extend-IA TNK1. The US guidelines, as far as I know, still has not been revised to reflect neither the ACT trial nor the ATTEST-2, but at least based on Extend-IA TNK, they say it's reasonable to choose tenecteplase with a 0.25 milligram in patients who are eligible for EVT. So what's next for thrombolysis? We talked about patients with minor stroke. Dr. Khatri talked patients who have other risk factors. Either they have uncontrolled hypertension, white matter disease, old age. Could we even lower tenecteplase instead of 0.25, go to a 2/3 TNK, like 0.18? This lower dose means better safety. Is there efficacy difference? That's still not known. At least for TPA, the lower dose, the 0.6, seemed to be safer than the full dose 0.9, but it was not non-inferior. So they couldn't show that it at least as good as full dose TPA. with patients on NOAC benefit from TNK. So patients on anticoagulation within 48 hours, there is evidence to show that the use of IV thrombolysis seem to be safe in those patient population. Those patients are typically excluded either based on INR or at least on history. But with NOAC, since we cannot test the INR, we have traditionally excluded those patients from IV thrombolysis, but the evidence seemed to suggest otherwise. Then we talked about bridging, whether at least for alteplase, there is no data to suggest we should skip thrombolysis, but we don't know whether that translates to tenecteplase. And then the CHOICE trial showed that after thrombolysis, after successful thrombectomy, if you give intra-arterial thrombolysis, those patients would achieve more benefit from intra-arterial thrombolysis, and whether that also the case with IA-TNK is unknown right now. So some of these trials are being planned and some have started to address some of these questions. But for the time being, for all comers with acute ischemic stroke, you can either give TPA at 0.9 milligram or TNK at 0.25. For bridging therapy, there is evidence to suggest that tenecteplase at 0.25 milligram is better than alteplase, but if you don't have it or it's hard to justify it in your system, I would suggest giving alteplase prior to thrombectomy. Beyond 4.5 hours, as we saw, there is no benefit for tenecteplase, but using MR, there is definitely some role for at least alteplase in those patients with DWI flare mismatch. That's all I had. Thank you very much. And you kind of intentionally wanted to keep it brief to give you time and to go over any questions that you may have. Thank you.
Thanks so much, Mohammed. That was very precise and enlightening with a lot of things.
Thanks.
Probably they are equivalent or non-inferior to alteplase, while the EXTEND trial showed a huge effect size, where the number needed to treat, I think was 10. So was that a random high, or because of the small sample size, or what do you think?
I mean, so in our trial, I said there was no kind of at least difference in outcomes. There was some difference or better recanalization, not necessarily reperfusion, but the clots seemed to be either move a bit distally or kind of migrate distally. I don't know. I cannot comment on one noticeable difference between the EXTEND IA and ACT trial and other trial is the EXTEND IA allowed patient who presented to primary stroke center. So a patient will present to a primary stroke center, get randomized, received either alteplase or tenecteplase, and then get transferred. So that gave more time for the thrombolytic to act on the clot. And there is evidence to suggest that the longer kind of you give alteplase or tenecteplase to act, the better effect it has. So with the caveat that I'm not recommending that in patients who arrive to comprehensive stroke center that we wait. But for transfer patient, definitely we have seen in many instances that there is more reperfusion if there is time for alteplase or tenecteplase to act. So I think that's probably why EXTEND IA-TNK showed that high number. ACT trial, I know for a fact that less than 5% of patients were kind of with large vessel occlusion presented to primary and then transferred. So that could potentially explain why the difference. I don't know, in a test too, they haven't presented their subset of patients with large vessel occlusion, but I suspect in the UK that mostly patients who received thrombectomy are the ones who presented to a comprehensive stroke center. So yeah, it'll be interesting to see how this unfolds.
Second question, Mohammed, if you allow me, the rate of angioedema, was it similar between TNK and alteplase?
They were rare on both arms, slightly in numbers higher in the alteplase, but there was no difference. We saw it, I think there was 2 cases in the alteplase and 1 in tenecteplase, if I'm not mistaken. So very exceedingly rare, but similar more or less.
So, Mohammed, now currently, as I understand that in Calgary, is it also in Canada that tenecteplase has been replaced by that alteplase has been replaced by tenecteplase?
Correct. Yes. So the guidelines give the option of using both. In Calgary and Alberta, it's tenecteplase has taken over, and in Quebec, as far as I know, and other provinces are rolling. There is kind of logistical issues as well, kind of to replacing, but at least guidelines give operators or physicians the option of choosing either or.
Good. There's many questions there, Fahad.
Claude is having a question about patient Muhammad on warfarin presenting with acute ischemic stroke, but the INR is 1.6. Can I give IV TPA? And she asked, small dose or regular dose?
So there is no evidence for low dose TPA as it is right now. I know many, and myself included, sometimes we give it to patient like anticoagulation or on dual antiplatelet therapy sometimes. However, if the INR, you said 1.6, Fahad?
Yes.
Yeah, so if the INR is 1.6, the current guidelines suggest if it's less than 1.7. So if the patient is not EVT eligible, then I definitely give thrombolytics. If patient is EVT eligible and there is any concerns beside kind of the use of anticoagulation, I think in these cases possibly you can just take the patient to the angio directly. But if the angio team is busy or they're traveling from out of the hospital, I think you can safely, or at least given the evidence, you can give IV thrombolysis and then proceed to thrombectomy.
There's a question, Dr. Muhammad, about the doses of tenecteplase. The question is coming about the cardiology who's using 0.5 milligram per kg for STEMI. How about the doses in the stroke? Is it the same? Is it smaller? And is there any trial regarding the safety dose?
Yes, so the current dose that at least the guidelines endorse is 0.25, so it's half the cardiology dose. The 0.4, there is no interest of people trying it, just because 0.25 seems to do the job, seems to have no safety concern. But the trial that is being planned or will be starting is for the lower dose, so even lower than 0.25, that's 0.18. It's almost two-thirds kind of the dose roughly. So that is planned, but there is no plan, as far as I know, to use 0.4 milligram or higher dose, just because NOR test 2 showed that there is actually significant concerns of safety and outcome with that higher dose.
There's a question regarding the lacunar stroke or subcortical with a TNK 0.25 compared to TNK in LVO. Is there any data about that?
So there will be data coming from the ACT trial, but as far as we know, it's non-inferior in comparison to alteplase. So if a patient either has no occlusion or you think it's subcortical presentation, you can give tenecteplase or alteplase. There is no safety concerns. I don't know what is the benefit compared to placebo, and I think that's what Dr. Khatri was saying, that if a patient present with either no occlusion or even no DWI, and you're convinced that this is an ischemic stroke, do those patients benefit from thrombolysis versus placebo? I think, at least from the PRISM trial and others for patients with mild stroke, it seems that there might be no benefit, but in patients with severe stroke and no occlusion and DWI, I don't know. There is no data to support thrombolysis. I personally would thrombolyze someone who present within the window, just because sometimes either the occlusion is too small or I don't have access to MRI, like for especially in patients who present overnight. And so I give the patient benefit of doubt if there are no contraindication. I think thrombolysis is probably safe in those patient population.
But someone is asking advantage of IV thrombolysis. Last two questions, Mohammed. IV thrombolysis.
Yes.
TPA, I can't stop it if there is a contraindication and bleeding, but TNK, the cat is out of the bag.
Correct. And with TPA, how successful are we in reversing? Like we always say, okay, we can stop the infusion, and I know we can. Hopefully, that gives us relief that we've done something. But is that enough to reverse thrombolytic effect? I'd say do your best to make sure that the patient doesn't have a contraindication, doesn't have bleeding. Tawakkal Allah, and then give the juice, as they say. But I think there is clear data of benefit. There is some harm, and it is a powerful medication, and that's why I think you just take a minute to think, is there a contraindication? Look at the CT again. If there is no occlusion, patient is disabled, look for any small subdural REM, especially with the subacute look for intraventricular hemorrhage. Scroll down with the CT, look at the cervical cord, especially in patient with weakness that spare the face. Is there any epidural or some cord hemorrhage that you're missing? And if you don't see anything, then the most likely etiology is a stroke. So just give the thrombolytic.
Ahmed, last question, and I know it's close to your heart. Any role for intra-arterial TNK? And if so, what is the dose?
So there are ongoing studies. So the Techno trial in Europe is using 3 milligram dose. Others are using 1/5 of the dose of full TNK, so 20% of the dose. But these are all in trials. Choice study, which I kind of alluded to for intra-arterial TPA, used 1/5 of the TPA dose. I don't know if it has a role. It is a very intriguing question. Choice showed that there is benefit. I'm hopeful there is benefit, because once we achieve reperfusion, typically we stop. We think we've given the patient the maximum benefit, and we hope that with rehabilitation and secondary prevention measures that will help them reach independence at 90 days. But if there is a medication that would even improve these chances of recovery, I think we're all excited to try it and see if it works or not.
Thank you so much, Mohammed. And always, it's a great pleasure to see you and learn from you.
Likewise.
And I will hand the mic to Prof. Suhail to have the last remarks and close the session.
جزاك الله خير. الله يسلمك يا فهد. Thank you, Dr. Mohammed. Our audience, it was a pleasure to start this year with two distinguished speakers and two young neurologists, stroke specialists who's growing, two ladies. And today we had the evidence for TNK in acute stroke by Dr. Al-Makhlafi, who showed us all the evidence, the update, and the new clinical trials which is coming in that field. Also, we had Dr. Pooja Khatri, who spoke about IV thrombolysis of mild stroke, and she enlightened us with the evidence behind TPA or thrombolizing mild stroke cases. Then we had two nice cases by our colleague, Dr. Khulud and Salama, about wake-up stroke protocol and regarding IV TPA for large vessel occlusion, LVO. And I'm so honored that Dr. Fahad Al-Ajlan is with me today, and it's so pleased to see both of Muhammad and Fahad again working in educating the Middle East and Arab world regarding acute stroke management. And I'm sure after 37 webinars has been going over the last 3 years, this year will be something new that we should be proud of. And we missed this year to put the announcement for the World Stroke Congress, which will be in October this year in Abu Dhabi, in UAE, in Middle East for first time. And promise that it will be a landmark, inshallah, Fahad and Muhammad. And thanks again for all our audience for being with us today, and wish you a great night.
Thank you very much, Suhail and Fahad, and everyone for your attendance. Thank you.
Assalamu alaikum. Thank you.
Alaikum assalam wa rahmatullahi wa barakatuh.